practice of clinical rheumatology means that we deal in a world of pain. Most of the patients who walk into a rheumatologist's office come because they are hurting. They have pains in their muscles or their joints or their spine. But sometimes we see patients who hurt all over. Every muscle, every joint, every tendon, every ligament is painful and may be tender when you feel them. And when those patients are seen, the rheumatologist has to go to considerable lengths to look for evidence of disease affecting their skeleton, inflammatory disease, metabolic disease, degenerative disease, autoimmune disease. And so we investigate those patients looking for signs of organic disease causing a state of pain everywhere. Now sometimes we find no such disease in place. Sometimes we are therefore faced with a patient who hurts all over but has no obvious disease in the tissues that hurt. If you cut out their muscles that hurt, look under a microscope, no disease. If you cut out a joint that hurts and look inside it, no disease. If you do blood tests looking for all of these metabolic abnormalities that can cause widespread pain, no disease. That is the patient, therefore, we define by the term chronic widespread pain. Capital C for chronic, capital W for widespread, capital P for pain. And when a rheumatologist diagnoses a patient as having chronic widespread pain, it means they hurt all over and there's no organic disease. Therefore, the messages of pain, the messages of tenderness are not coming from the tissues, they're coming from the patient's own brain, from their own central nervous system, from their spinal cord and brain pain pathways. They're feeding the upper levels of the brain with false information that everything hurts and everything is tender. Now, in reality, there are only two causes in clinical medicine, two common causes for a state of chronic widespread pain. One causation is a condition called fibromyalgia, and the other condition is an identical clinical picture, nearly identical, caused by psychiatric disease. In the condition of fibromyalgia, we believe there is abnormal sensory processing in the patient's central nervous system, so that things that shouldn't hurt do hurt, things that shouldn't be tender are tender. Even the activities of moving the body become a source of pain. In the patients with psychiatric disease, there may be a state of anxiety, of depression, of great stress, and there they may develop psychophysiologic symptoms. And those psychophysiologic symptoms may cause headaches, may cause irritable bowel, may cause non-cardiac chest pain, may cause a sense of shortness of breath, may cause irritation of the bladder, may cause painful sexual intercourse, and yet there's no disease in those organs. Those are psychophysiologic symptoms. And in the musculoskeletal system, the patient with depression or anxiety may develop muscle pains, joint pains, with or without tissue tenderness. So that is the problem of chronic widespread pain with the differential diagnosis of fibromyalgia or depression. Now, it may not be as simple as that. If somebody has true fibromyalgia going on for months and months and years, not only do they have pain, but those pains keep them awake at night. They wake up tired and stiff in the mornings. They're exhausted in the day. If you get no sleep and you're chronically sleep deprived, your brain doesn't work as well. You have cognitive problems. So patients with fibromyalgia often have a sleep deficit, often have undue fatigue, often have cognitive problems due to that fatigue. And if you're in that condition for months or years, of course you get depressed. So many patients with fibromyalgia may eventually become depressed, and then they may have the symptoms of depression superimposed on the fibromyalgic state. One of the greatest challenges in clinical rheumatology is to handle and help patients with that condition, help them to manage their pain so they can cope with life. The way doctors treat fibromyalgia is to try and lessen the dysfunction, improve bodily function, help patients cope with these pains, and help patients cope with the insomnia and cope with the fatigue. Now, for many patients with mild fibromyalgia, we can use various medications to lessen the pain state. We can use mild medication to promote sleep. We can have patients exercise. But without good sleep and without exercise, that person with fibromyalgia can never improve. In patients with severe fibromyalgia, where there's a great risk of disability, the best way to go is to teach patients to cope. We have to teach patients to cope with pain. We have to teach patients to exercise despite the pain, exercise without hurting themselves. We have to teach the patient how to sleep without taking a lot of potent drugs that can make you groggy, that can give you fatigue during the day from that grogginess. We have to teach patients to sleep in a natural manner through sleep relaxation techniques, through meditation, through certain safe medical foodstuffs. And we have to teach the patient to take control and receive credit for so doing. That's a process called cognitive behavioral therapy. So if we see a patient facing disability from fibromyalgia or facing disability from the psychophysiologic symptoms of depression or anxiety, teaching them to cope is the essence of a fine rheumatologic practice.